Thank you, Sripriya, and good evening, everybody. So we are at the end of our uh, session, and uh, today Dr. Theo is going to talk on methadone. So methadone, uh, it is a newer, not newer. It is a newer medicine in Indian market for pain relief. Which was available since 2018. And I believe many of the palliative care institutions do not use methadone because of its associated problems. But methadone was already available in India as an oral substitution therapy for opioid dependence. And today, we will see how methadone can be used safely for pain management. And today's session is by Dr. Theodore, and he is the adjunct assistant professor for palliative care at University of Iowa College of Pharmacy. And he is a clinical pharmacist at the Los Angeles County Department of Mental Health. Theo has been helping us with various parts of palliative care, and he has been involved on training how methadone can be used, and he has got training in palliative care also at University College of Iowa. So welcome, Theo, and it's over to you. And I know Theo is recovering from an infection, but still he agreed to take this session. So welcome, Theo.
Great. Thank you for the introduction, Dr. Sunil, and I apologize for the participants if I'm coughing in the middle of the presentation, so bear with me. Let me share my screen. Okay, is everyone able to see my screen?
Yes, Theo.
Yes, sir.
Thank you.
Yes.
Yeah, so with today's lecture, we'll be talking about methadone and several aspects of it, where we'll be talking about the pharmacology and the risk and benefits of using methadone, and then also you recognizing safe parameters on using methadone and which patients may be appropriate, and then briefly at the end run through conversion ratios and also calculations. So the first part of methadone that's important to know is what are indications that can be used for. So in the US, there's two major indications. The first one, when it was initially developed for, was for opioid use disorders to help with withdrawal symptoms and addiction use, but also it has the benefits of pain management. And in regards to pain management, the main things that we look for where methadone can help with is chronic pain that is around the clock pain. It can be used in pain management in patients that have renal impairments, neuropathic pain components, or even help with aspects of opioid tolerance and or hyperalgesia. So as we've talked about in the beginning courses on opioids, it does share similar side effects with most opioids. So the most common ones being constipation, sedation, nausea, potential hypotension, and urinary retention. With more chronic use, There's the risk of opioid-induced androgen deficiency, even immunosuppression, and osteoporosis. For more serious side effects of opioids is respiratory depression, and a little bit more specific to methadone is serotonin syndrome and potential QT prolongation, which can potentially lead to torsades. And the latter two are the main significant ones that makes methadone a little bit more infamous with its side effects. But as we'll talk about later, there's a few things that we can keep in mind. That way we can effectively and still safely use methadone for pain. So touching on to the pharmacology of methadone, the receptor activities of it is it works as an opioid receptor agonist on the mu, delta, and kappa opioid receptors. It also acts as an NMDA antagonist and also is a norepinephrine reuptake inhibitor and also a serotonin or 5-HT reuptake inhibitor as well. And when we look at methadone, it is a racemic mixture component comprised of an S enantiomer and an R enantiomer. And when we look at the two different properties between them, the S enantiomer actually has 3.5 times higher activity on the cardiac human, either a go-go related gene or the HERG gene, and causes a blockade on that. And where that falls in place is that is where a lot of methadones causes for QT prolongation by blocking the delayed rectifying potassium channel. And then with its R enantiomer, it's thought that that enantiomer has up to 8 to 50 times more of the analgesic potency. Further talking on pharmacokinetics is with methadone, for its oral availability or PO, it is thought to be anywhere between 36 to 100% bioavailability, with on average around 80%. And when administered sublingually, especially when given as in the syrup formulations, it's thought that the sublingual absorption is really only 30%. But to keep in mind, when you are administering the liquid formulations, even though it does have poor sublingual or mucosal absorptions, patients typically are still trickling down their throat. So it is still going to be PO absorption. And then just for completeness sake, when we do consider oral versus IV methadone, which I know it may be very uncommon or not quite available in India, there is specific conversions to keep in mind where we always are more conservative. So if at any time in the future, if you find yourself having a PO or an IV methadone formulation available, this is just for you to keep in mind. So if someone is on a PO methadone and you needed to convert to IV, we would usually do a 1 milligram to 0.5 milligram ratio. So you would half the dose. But the other way around, if you had someone on the IV methadone to a PO and switching to an oral formulation, then you would do a 1 to 1.2. And this is the main purpose of this is to be more conservative whenever you're doing this conversion, because we can always titrate up to, excuse me, we can always titrate up to effectiveness for pain management. But again, this may not necessarily be applicable in your practice setting, but this is something just to keep in mind in the event that it does become available. And when we think about methadone, one unique aspect of it is it does have a very unique pharmacokinetic profile in the body where it is biphasic. So there is a much bigger distribution within the plasma and tissue compared to some of the other opioids that may be a little bit more hydrophilic. So this leads to methadone having a much longer chemical half-life rather than other opioids, which may come in immediate release and also come in extended release formulations. So on average, we would typically say that methadone's half-life, or the time it takes for the body to eliminate half of a dose of methadone in the serum, is around anywhere between 8 to 59 hours, but on average, we would say around 22. In cases where people have hepatic impairment, it can take as long as 120 hours. So when we talk about this biphasic distribution, the best way to look at it is when someone takes it orally, it's absorbed into the gut, and that gets absorbed into the plasma. But because methadone is more lipophilic, it distributes between the tissue. So then whenever we talk about the half-life, it is extended because there is this constant flux between the two, which leads to a longer time for it to be eliminated from the body. And then in regards to the metabolism and elimination, as we talked about before with the opioid lecture, it is more cleared through metabolized through the liver, with the metabolites excreted renally. But the main thing is we look at hepatic function. And with methadone, despite it having a long half-life, we note that its analgesic effectiveness is typically lasting every 8 to 12 hours with repeated dosing. And this is important to keep in mind because this will impact how we typically administer it or provide dosing for patients. And that aligns with usually seeing a BID or TID dosing, or 2 times a day or 3 times a day, or every 8 to 12 hour dosing. So again, as I mentioned before, with its metabolism, it is extensively hepatically metabolized. So we do caution with hepatic dysfunction. This is not a contraindication, but just a caution, meaning that we would want to make dose adjustments more slowly and monitor more carefully. Some of the few times we would really want to avoid it is if there's unresolved biliary obstruction, which would cause issues with being able to clear. And in regards to hepatic metabolism, we do want to keep in mind CYP metabolism. So the substrates of these different enzymes for methadone is the major ones we want to keep in mind is 2B6, 3A4, 2D6, 2C19, and the ones listed in green are highlighted because things to keep in mind is all 3 of these different CYP enzymes are prone to pharmacogenetic variations, meaning there can be differences in people's genetics, which leads to a difference in activity or even expression of these CYP enzymes. So there can be a variable ability for someone to clear a medication faster or even slower. And then additional CYP enzymes to keep in mind are 2C9, 2C8. And because it is a substrate for many of these different enzymes, we want to keep in mind different drug interactions. So this may impact your clinical decision for considering methadone, or how you may want to adjust the dosing. But we'll talk about some potential drug interactions and mnemonics to help remembering when we talk a little bit later about methadone dosing and conversions. So as we mentioned earlier, that some of the risk factors that, or one of the biggest cautions with methadone is QTC prolongation or torsades risk. So some base foundational information to keep in mind with this maybe heightened concern that people have with torsades is knowing what population may be higher risk that we may be concerned about. So things to keep in mind would be patients that have electrolyte abnormalities, patients that are over the age of 65, females, patients with structural heart disease or genetic predispositions or other QT prolonging medications, or history of syncope or previous ECG that showed a QTC of over 450. Oops. So when we look at these different risk factors, each risk factor had an odd ratio of increasing a risk of torsades by 3.2, and patients that had 3 or more risk factors has an odd ratios of 9.19. And when we look at other predictors of QT prolongations, these can include conditions such as heart failure, hypokalemia, hypocalcemia, patients taking medications with known torsades risk, rheumatologic diseases, malignancies, peptic ulcer disease, and patients taking methadone doses over 45 milligrams each day. So when we think about monitoring parameters, things to keep in mind is how we approach monitoring and following up with patients really should be aligned with the patient's goals of care, in addition to these weighted risk factors that we listed earlier. But again, the main emphasis is aligning them with goals of care, since aggressive labs or ECGs may not be warranted or necessary in patients that are geared more towards comfort-focused care and maybe don't have as many risk factors. And these discussions of the risk and benefits should be discussed with patients with what they're hoping for and what they would like to be involved with their goals of care. So when we do monitor, generally speaking, again, and remembering all of these are aligned with goals of care, but if we can have a baseline ECG and some baseline electrolytes, and some of the most important ones to have is potassium, magnesium, and calcium. Since we mentioned earlier, some of the risk factors may be hypocalcemia, hypomagnesemia, and low potassium. And when we follow up, some recommendations for when we would want to do a repeat ECG is typically 2 to 4 weeks after initiation of methadone. When we titrate doses of methadone, when we reach dose thresholds anywhere between 30 to 40 milligrams a day, and also if we hit the point of 100 milligrams per day of methadone. And additionally, if patients develop any new risk factors or signs and symptoms that may suggest potential arrhythmia. And these will all are points where we may want to do a repeat ECG. And then we would always want to monitor for potential adverse effects and then wait sufficient time for steady state before we make dose adjustments. So generally, based off of the half-life of methadone, right? So in patients with normal hepatic function, that's around the 22 hours. When we look at steady state, that's 3 to 5 half-lives. So that would be around 5 to 7 days. Or in patients with advanced age or hepatic impairment, then we would want to wait between 10 to 14 days. So looking at methadone and QTC intervals in advanced cancer, there was a prospective study completed in MD Anderson where they looked at 100 cancer patients and monitored ECG changes from baseline at 2 weeks, after initiation at 4 weeks, and 8 weeks. And the results of their study, they found from baseline prior to initiation, 28% of patients have QT prolongation. The median dose of methadone in their study was around 23 milligrams per day. When they looked at the 2-week mark, 31% of patients had prolonged QTC, and then only 1 patient had a QTC over 500. And no patients had over an increase of 25% from their baseline, and they didn't have any events of torsades or ventricular fibrillation. So with this concern, this heightened concern of QT prolongation, this shouldn't be a deterrent from using methadone as an effective option or medication that can be used for pain management, especially in palliative care. And one thing to keep in mind is the limitation from this one study is they did have significant dropout. So now, talking about some of these, we're thinking about what might be appropriate candidates for methadone. So when we think about patients and who we want to consider for methadone, these may be patients that have moderate to severe pain, pain refractory to other opioids, or even patients that have significant renal impairment, or if they need long-acting opioids, so around-the-clock pain, and patients with high opioid tolerances. And then also patients that have poorly controlled pain or poorly controlled opioid-induced adverse effects with other opioids. Or if patients have true phenanthropy allergies or morphine allergies, since methadone is a synthetic opioid, so you do not have to worry about the cross-reactivity and allergies. In this next subset of patients, these may be patients that we may want to be a little bit more cautious with, or have a little bit more reservations or just more monitoring. So patients that have a history of structural heart disease, if patients have a QTC of over 450 but under 500 milliseconds, patients with severe chronic liver failure, history of non-adherence to therapies, so patients that aren't able to remember to take medications as prescribed or follow directions, you may want to have a little bit more caution. But if they can have someone such as a caregiver that can help with managing the medications. Patients with history of sleep apnea or central or obstructive sleep apneas. And patients with multiple non-modifiable, and non-modifiable being like unavoidable, like they can't be switched on alternative therapies that may have drug interactions with methadone, or patients that have multiple non-modifiable torsades or QT prolongation risk factors. Again, this subset of patients are patients where we can still use methadone in, but we may just want to be more cautious, maybe conservative with initial dosing, or have more frequent monitoring. Lastly, is a list of patients that we may want to avoid using methadone in. So patients that have a family history of sudden death, congenital QT syndrome, a QTC of over 500 without modifiable risk factors. So an example of a modifiable versus non-modifiable is if someone had electrolyte abnormalities. If you're able to correct that, then that potentially can fix or reduce their QTC, versus non-modifiable risk factors would be, say, congenital or structural heart disease, right? Or patients that have poor cognitive function, in addition to living alone without a reliable caregiver for support. Or patients that are unable to obtain follow-up, or patients that have illicit drug use or misuse, in particular stimulants such as cocaine or amphetamines, because these may also increase their risk for arrhythmias. And also for patients that are having an acute pain crisis or acute pain management. And this is because methadone, right, we know that it has a long half-life and it may take some time to get to an adequate level or dose titration. So methadone might not be the best place to be used in an acute pain crisis, or patients with acute liver failure. And so for right now, I know I wanted to take a pause for if anyone had any questions before we proceeded to methadone conversions.
Any questions till now?
Regarding this sleep apnea, you had told we have to be cautious.
Mhm.
So what should we be like monitoring? Respiratory rate monitoring, or we should do a complete sleep study, or just the history of sleep apnea should prohibit us, or what should we, how should we?
Right. So, so in that regards, it would be more monitoring respiratory rates, and if they do have history of like essential or obstructive sleep apnea, right? I think it would be monitoring maybe with the caregiver if the patients are sleeping, just to make sure that they're still having regular breathing. If they are having significant apneic spells, then I would maybe look at, is this patient on any other CNS depressant? If they are there any other ones that we can maybe remove or reduce the dose to mitigate that risk? But to keep in mind, right, all CNS depressants can add to this risk of apnea or reducing the respiratory rate.
Okay, so
But I wouldn't say it's an absolute contraindication.
okay, should we go with dose reduction for that?
Dose reduction with methadone. Well, if they have that history, right, we can, and they don't have any other contraindications or drug interactions, then I would say that typically speaking, I think if we're not worried about reduced metabolism, I think you can proceed with normal doses. You can be conservative and slowly go up. But the biggest thing is just monitoring, just like you would respiratory rate.
Thank you, sir. I have another question. You told us that acute pain crisis, we cannot like depend on methadone because of the long half-life. So if the patient whom we have started methadone comes for a dressing change or some small procedural thing which needs uh, potential high potency pain relief, can we combine any other opioid on top of it, like fentanyl, or
Yeah.
how should we go about it?
Yeah, so exactly like you said, you can use any other opioids in combination with methadone. Since we want to treat methadone as that long-acting or a basal opioid, so you can still, the patient should still have a breakthrough dose, but if you're doing things such as dressing changes or things that will have high incidental pain, then you can definitely use these other opioids, like you said, like if it's procedural, IV fentanyl, or an oral morphine dose before the dressing change to help with the acute pain.
Sir, and one last question regarding this renal failure patients or patients on dialysis. Is there a dose change for methadone?
So methadone can safely be used in renal failure and even on hemodialysis. When you're initiating someone on methadone, you could be a little bit more conservative or slower with the dose titrations to be a little bit more cautious. But generally speaking, methadone can safely be used with end-stage renal failure and on dialysis.
Sir, like the frequency should be changed or the dosage?
Well, with the dosing can be the same, but if you felt more hesitant, you can empirically start at a lower end of normal dose and monitor. But generally speaking, it shouldn't necessarily cause you to need like an empiric dose reduction.
Okay, sir. Thank you.
Dr. Nguyen, how high a dose can we go with methadone?
So in regards to like a dose cap on it, I wouldn't necessarily say that there is a dose cap, but when we talk about conversions, which we'll go into a little bit, when we just start someone and convert someone onto methadone, we typically would say not to go any higher than 40 milligrams a day, but this is going to be from someone that's quite tolerant already on opioids. But I'll also run through dose recommendations for like a brand new start on an opioid naive patient as well.
And for breakthrough pain, can we use morphine?
Yep, you can definitely use another opioid that's shorter acting for breakthrough pain. Any additional questions?
So which are the other drugs with which there are cross reactions? Because you mentioned that because of the SIP, there will be a lot of drug interactions. So which are the other drugs?
Okay, so I will have a list of some of the medications and also a website resource that we can use to check for QTC prolongation and drug interactions as well. But that's a great question. Thank you for bringing that up.
Thank you, sir.
Okay. So, excuse me. Sorry, so moving forward, with methadone conversion factors, things to keep in mind is methadone does not have a linear conversion ratio. And this is due to methadone's activity on the NMDA antagonist, which we mentioned earlier may help with reducing some of the opioid tolerance, hyperalgesia, and neuropathic pain benefits. And then there are many different methadone conversion factors that are available, but the one that I'll be touching upon will be the white paper consensus, which really has simplified the conversion ratio and is already very conservative, which can help with alleviating some of that stress when we compare to some of these other conversion ratios that do get quite long and confusing. And when we do the conversions, some of the important aspects to keep in mind is determining the basal opioid requirements before we do a conversion. And then also remembering to ensure that patients have sufficient breakthrough medication. So that may be short-acting opioid medications, right? Because we want to treat methadone as quote unquote like the extended release or the basal opioid. So when we look at the hospice and palliative care consensus white paper, when we look at patients that are opioid naive versus opioid tolerant, the definition of opioid naive would be any patient that's currently using less than 60 milligrams of oral morphine equivalents, or OMEs. And for an initial dose that would be reasonable is a dose anywhere between 1 milligram every 12 hours up to 2.5 milligrams every 8 hours. So that's anywhere between 2 to 7.5 milligrams. An average reasonable is also 5 milligrams a day, right? And what would make you decide between the two for any opioid naive patient is if you say you have someone that is older or more frail or may have other risk factors, right, for slower metabolism or even drug interactions, then you may want to err towards maybe this more conservative approach. When we look at patients that are opioid tolerant, there's a few factors to keep in mind. How much are they currently using on their opioid requirements? So if a patient is using 60 to 199 OMEs per day, and they're 65 years or older, then you can use this conversion ratio of 10 to 1. So 10 milligrams of oral morphine equivalents to 1 milligram of oral methadone. If a patient is using 200 milligrams or more, or they are using quite a bit of opioids and they're over 65, then we would want to use this more conservative approach, right? And if they're over 65 years old, we're using this more conservative ratio because we may be empirically assuming that they may have impaired hepatic or slower metabolism, right? And the key things is regardless of whatever calculation that we get from a conversion factor, if this is a new start with methadone, we don't want to exceed 40 milligrams of methadone a day. And then this conversion already includes a factor of incomplete cross tolerance. So we don't have to do that additional reduction when we switch to a different opioid. This conversion factor already includes that for us. So this gives you a sense that this ratio is already very conservative. And then this conversion ratio should only be used unilaterally, not the other way around. So it's from other opioids to methadone. If we want to switch from methadone to other opioids, then we would use a different number, but we definitely do not want to use it the other way around. So when we already convert a patient, right, if we've noticed that they may need increases of their doses, then typically speaking, if a patient is on less than 30 milligrams of methadone a day, then we would not want to increase their methadone dose by more than 5 milligrams a day at each titration period. And then we'll talk about the titration frequency on the right. And if a patient's using 30 milligrams of methadone a day, then we can consider going up by 10 milligrams per day. And this is each titration period. On how frequent we would want to potentially go up on the dose, right? This is dependent on the steady state based off of the half-life elimination. So in a patient that has normal liver function, we wouldn't want to increase the daily dose until 5 to 7 days, because that's the time the patient would reach steady state, and we would know that they've reached their maximum analgesic benefit from each dose of methadone they're on. And when we look at the patients with hepatic impairment or more advanced age patients, then we wouldn't want to make dose adjustments until 10 to 14 days. In regards to the discussion on drug interactions, because there are so many SIPs that are involved with methadone metabolism, a good rule of thumb or mnemonic that can be helpful for the most frequent drug interactions are GPAC-MAN, which is a mnemonic. So grapefruits, protease inhibitors, azole antifungals, cyclosporins, cimetidine or cobicistat, macrolides, amiodarone and dronerone, and non-DHP calcium channel blockers. On the other end, versus inhibitors, for CYP inducers, and the mnemonic that we used back in my pharmacy school was PS-Porks, so phenytoin, patients that are smoking, the use of phenobarbital, oxcarbamazepine, rifampin, rifabutin, rifapentine, carbamazepine, and St. John's wort. And a good rule of thumb is if it's possible to avoid using strong inhibitors or inducers for a same therapeutic use, then try to use alternatives first, especially in patients that are on methadone. But again, this isn't necessarily a contraindication, but things to keep in mind because that may impact metabolism and drug levels. So if someone is on a medication and there's no alternatives or you can't switch it, it doesn't mean that you can't use methadone, but how do we address this, right? So when we think about inhibitors, key things to think about is the inhibitors are actively impacting the enzymes themselves. So if patients are on medications that are inhibitors, the peak effects of these other medications typically occur within 1 to 2 days. And when we look at inducers, these are typically impacting the body's expression of the CYP enzymes. So typically there's a bit more of a lag effect where it can take 1 to 2 weeks for the body to start producing or expressing more of these CYP enzymes because of the induction. So when we talk about the empiric use of drug interactions for patients with methadone, if a patient is starting an inhibitor, or if they're stopping an inducer, meaning they're already on it, but the plan is for them to stop it, this would mean that this may impact their ability to metabolize methadone in the same rate. So they may have a decreased metabolism. So you may want to be conservative and empirically reduce the methadone dose by 25 to 33% and monitor carefully. And we can always go up on the dose, but the priority is to keep to be safe and more cautious. If patients have increased pain during this time, then this can be a time where you want to make sure that you are providing adequate breakthrough dosing, just in case, right? On the other end, if we stop an inhibitor or we're starting an inducer, that means we may anticipate increased metabolism of methadone. Typically, we won't empirically increase the dose of methadone. We would keep it the same and monitor for increased pain or potential withdrawal symptoms. But we can provide adequate breakthrough dosing or short-acting medications to supplement while we find out what their opioid requirements are. And then we can use the conversion ratios to increase the methadone doses and get their pain better controlled. And again, all of these approaches or aspects are to be pretty conservative and make sure that we are safely using methadone to effectively control pain. So for more resources regarding CYP interactions, I've included a link from the Flockhart table. So this is a comprehensive website that includes a lot of different medications that lists CYP inhibitors and also CYP inducers and their relative strengths, which is a great resource and it's pretty comprehensive. In regards to other medications that may have risk for QT prolongation, Credible Meds is a great resource to utilize as well, where you can put in medication names and check what their QT or Torsades risks are. I believe if you use the mobile application, it's free. And then if you use the web browser or the website, it's free. They may require you to register with an email just to be able to utilize it. But both of these resources should be pretty comprehensive and also free. Okay. So now going into a little bit of basics for calculation practice. So let's say we have a 57-year-old male with history of stage 4 pancreatic cancer with metastasis to spine and liver, presenting to outpatient palliative care clinic with concerns of uncontrolled pain in his back and legs. And he describes neuropathic pain. And his current regimen is morphine 60 milligrams PO, Q4 hours SOS. He says on average, he's using around 6 doses a day. Sometimes his pain is significant enough where he's needing to use 7 doses a day. So let's assume this patient is a good candidate for methadone without any contraindications. What dose would you recommend? Okay. So when we go about this, right, and I see someone put a recommendation for the 2.5 milligrams every 8 hours. So that's a good thought because it is a new start. But kind of going back, would we consider this patient opioid tolerant or opioid naive? Yeah, so someone mentioned they would consider them opioid tolerant. So the most important thing when we go about this is to calculate what their basal use is. So we know they at least need to use the 6 doses every day consistently. And they're using 360 milligrams of morphine per day. So it's 360 OMEs. And how much of this would you convert? And if the pain is uncontrolled, it's reasonable to convert all of this OME to methadone. The only times that we generally may consider not converting 100% of it, of their requirements to the basal, is if we anticipate other therapies which may significantly reduce their pain. So if they're having palliative radiation or palliative chemotherapy, this is the times when we generally can consider converting less than 100%, but generally keeping in mind that this conversion ratio is already conservative. So we're not necessarily too worried about this, right? Because we know that they need 360 milligrams of oral morphine a day and their pain is significant, and we're using a very conservative ratio. So the next question would be, what ratio do we use? Should we be using this 10-to-1 or this 20-to-1 ratio?
20-to-1.
21? Okay.
20-to-1.
So yeah, so when we bring up this table back again, right? This is a 57-year-old male. So they're less than 65 years old, but they are using over 200 OMEs. So based off of that, we would be using, like you mentioned, the 20-to-1 ratio. So when we do this conversion, if we do the 20-to-1, then that would calculate to the 18 milligrams of methadone a day. And then remember that the duration of analgesic benefit lasts anywhere between 8 to 12 hours. So the final methadone regimen will be dependent on the formulation that's available to you. So in India, it's currently available in 5 milligram tablets and also 5 milligram per ml syrup. And you can always round down to the best fit depending on the available formulation. So for example, if we are using the tablets, then we can consider doing 5 milligrams, 1 tablet every 8 hours for a total of 15. If we're using the syrup, that gives us a little bit more flexibility where we can do the 9 milligrams or 1.8 mLs every 12 hours. So that's 18 milligrams. Or if we wanted to break the dose to every 8 hours, then we can do the 6 milligrams or 1.2 mLs every 8 hours. So that would be 18 milligrams per day. And so for the SOS dosing, we want to make sure that we're still providing something for breakthrough pain. So when we're thinking of SOS dosing, right, the patient was previously on morphine IR, 60 milligrams SOS. That might be a little too high for us to continue as an SOS dosing, right? Because we've added on the methadone that may help with the opioid tolerance, control other aspects of neuropathic pain. So a general rule of thumb is when we're doing an SOS dosing, the breakthrough dose can be anywhere between 10 to 15% of their daily OME requirements. So we know that they were needing 360 milligrams per day. So if we do a conservative number of 10%, then that would give us around 36 milligrams of morphine, right? So we can be conservative and round down. And then if we want to double check this, right, just to give us a sense, how much does that equate to? So if we did an available SOS dosing of 30 milligrams of morphine, and we allow them to have it up to Q4 hours, so that would be 6 doses a day, we're giving them the option of up to an additional 180 milligrams. That doesn't necessarily mean that they're going to take all 180 milligrams, but they could use up to it if they need it for the breakthrough dosing, right? So one thing is some people may get scared and say, well, then will I be giving them too much if I'm giving this much? The main thing to really counsel again is because they're starting this methadone, that the SOS really is just for breakthrough pain as we wait for time for this methadone to build up. Because we know the dose that they're going to get all the time is the methadone. But if it's not adequate, then they can consider to use the SOS to give that time. If they're still consistently using the SOS dose, then this would be a time where we would consider to continue to go up on the methadone. But for this example, regimen, it would be let's say we chose the 5 milligram tablets because they prefer that over syrups. Then we can do the 1 tablet every 8 hours. So that's the 15 milligrams of methadone a day. And if they have the morphine IR, 15 milligram tablets, then they can do the 2 tablets every 4 hours as needed for breakthrough pain. Okay. And so what do we do now when we do a follow-up? So let's say the patient reports pain's improved, and previously it was 8 out of 10 pain. And now they're saying it's still a 6 out of 10, which is still uncontrolled for them. And currently they're on the methadone dose. It's been a week, and they're still using their SOS dose every 4 hours. So they're using 6 doses of the 30 milligrams. How would you approach adjusting the patient's pain regimen? So what would the first thing that you'd want to do before we proceed? So you'd want to first calculate how much they're currently using for their OMEs. So if we do those 6 doses of the 30 milligrams, then we know that they're using an additional 180. And they've had adequate time. So like I said, they've been on this dose for 7 days. So this has been enough time, and they're still using the same amount of OMEs with the breakthrough dose. And so if we want to determine how much this SOS dose would be equivalent to methadone, if we wanted to be conservative and convert 50% of their SOS dosing into basal, then you can still use the 1 to 20 OME. If their pain was significantly higher, right? So if they're saying their pain was a 10 out of 10 or 8 out of 9 out of 10, then I would maybe convert all of their OMEs over. But in this case, if they're saying it's moderate pain, then I might not feel as aggressive with it, right? But in this case, if it's 6 out of 10 and it's their ideal pain is say like a 4 out of 10, then that may be reasonable to be more conservative to do this conversion. So if we calculated the 90 and still did the 1 to 20 ratio, then that would be the 4.5 methadone a day, which we could then add on to their basal. And then since they were on the 15 milligrams of methadone a day, we want to keep in mind the maximum daily dose increase we would consider. So the most that we would go up per day is 5 milligrams, right? And this calculation is simply based off of just for us to reference how much each methadone dose would be equivalent to. But when we talk about these titrations, these are the maximums, just so we can keep that in mind, so we don't overtly aggressively increase the dose, right? And so in this case, we can increase by another 5, and they were currently on 15 milligrams a day. So we can change this from the 5 milligram POQ8 to 10 milligrams POQ 12 hours. So then they are now on 20 milligrams per day, right? So that's how we would go about with dose titrations with methadone once we've already started. And then so now I just wanted to open it up to questions.
Sir, does it ever happen that nociceptive pain component gets controlled, but the neuropathic still continues? Does that ever happen?
It's, I mean, generally speaking, from my experience, the neuropathic pain component, generally from my experience, does improve. There are some cases where they're still having significant pain with methadone, and it may take some time with titrations for us to achieve an adequate amount. But again, every case can be unique and variable, but generally speaking, from my experience, patients have found improvements with it.
So, and I just wanted to know whether we can prescribe, say, an opioid plus something for neuropathic, and in that case, suppose he's on morphine, he's well controlled pain, but the neuropathic component is lingering. So, methadone is the first drug of choice for neuropathic, or do we opt for the tricyclics first, followed by the gabapentins, and then think of methadone, or will just methadone take care of both?
Yeah, so I think that's a great question. So when we think about agents for neuropathic pain, right, we want to think about the mechanism of actions that we're targeting. So let me pull that up. So when we think about, so your example for TCAs, right? The TCAs work by targeting the norepinephrine reuptake inhibition for the neuropathic pain component, right? So generally, we wouldn't recommend adding a patient with a TCA in addition to methadone because we may be duplicating the targeted therapy. And also TCAs may also increase that risk of QTC prolongation. But say if someone is still having neuropathic pain with methadone, you could consider adding adjunctive therapy that's not targeting the same thing like a gabapentinoid, but keeping in mind that the gabapentinoid is also an additional CNS depressant. But I've had patients that were on both medications to help additionally for neuropathic pain, but generally speaking, with the broad receptors that methadone is targeting, it is targeting quite a different areas.
Thank you, sir.
And there's a question from Dr. Ravi.
Good evening, sir. Sir, if the patient neuropathic component is more than the nociceptive pain, can we straight away start with methadone? Or only after the trial of gabapentin, anticonvulsants, if not work, then only we switch over to methadone, or straight away we can start methadone? If straight away we have to start, what would be the dose, and if it achieved certain promising the comfort level to the patient, then can we stop? If we want to stop methadone, how can we stop in a phase-wise manner?
Right. So for the question is, if can you start someone initially on methadone, and the answer is yes, you can. You could start someone on methadone, and for the dosing, right, this would be the points where we would consider opioid naive patients. So the anywhere between the 1Q12 to 2.5 Q8. But would I just start everyone with neuropathic pain on methadone? Maybe not, just because there are additional monitoring things to keep in mind. And if there's other agents that can adequately control their pain, I would probably try some of these first, but it wouldn't be unreasonable, say, if they have some of these other risk factors, right? If they have pain, they have neuropathic pain, it's around the clock, and they have renal failure, then I would think it's reasonable to start them initially on it, right? But I think a lot of it, the discussion would be having a shared decision making with the patient and having them be aware of the risk and the monitoring that may be involved depending on where their goals of care are at. And sorry, I forgot if you had additional questions that I may have not answered.
Yes, sir.
Oh, and if you wanted to have someone come off of methadone. So when you asked that question, was that to come off of methadone completely, or do you mean come off to switch to another opioid?
Sir, both questions, switch to other opioid and well as to completely off in cases.
Yeah, so if
like,
you're taking someone off of methadone to be off of opioids in general, I would treat it similarly, right? Where if you're tapering someone off of opioids, it does need to be done slowly over time, just to prevent withdrawal symptoms. And a rule of thumb is a reduction anywhere from 10 to 15% over weeks to months, and that will just depend on how patients are tolerating that dose reduction. Typically with methadone, because it's a little bit longer acting, the dose tapers shouldn't be as drastic because there is that longer half-life compared to maybe tapering off of just short-acting opioids. If you're doing a conversion from methadone to another opioid, I believe the ratio from, I forgot the name of the study, but it's a 1 to 4.7 conversion ratio. So for one methadone to 4.7 milligrams of oral morphine equivalents. So again, you wouldn't, for these conversions, it's from other opioids to methadone. And then if you do, for some reason, need to switch from methadone to another opioid, then you can do the 4.7 to 1 from methadone to another opioid. Is there any other additional questions?
Sir, as you said, 1 mg every 12 hourly for the frail patients, older patients. We have a 5 mg tablet. So how can we do to 1 mg every 12? How can we?
Right. So that would be a little bit more limited with the tablets. So it would be reasonable, depending on how concerned. Generally, I wouldn't recommend splitting tablets beyond half, but you could do, if you did a quarter tablet, then that would be 1.25 if they have the dexterity or a caregiver to break it that much. But generally speaking, I wouldn't. You can also start them off with 2.5 milligram per day and see how they do with that, and then increase to 2.5 Q12.
Okay, sir. Thank you.
And then I think other questions, if methadone can be given to pediatric patients. Yeah, methadone can safely be used in pediatric patients. And is there any additional questions?
No. Anybody?
What is the maximum dose of methadone, sir?
So there isn't a dose maximum for methadone, but generally speaking, when we use methadone in pain, most of the time, you'll be seeing patients in the range of 30 to 40 milligrams. They can go higher. Typically, much higher doses of methadone I don't see very common. It's typically more in opioid use disorders or addictions where I've seen doses as high as 160 milligrams of methadone a day.
Thank you. Like in morphine, we have delirium. Do we have any symptoms so that we can stop the medication or reduce the symptoms?
So with delirium, so methadone is again an opioid, so it can still also have that risk of delirium, right? But with the added benefits of the NMDA antagonism and also the norepinephrine, it can potentially reduce opioid requirements. So they may actually need a lower overall amount of opioids, which may empirically actually help us with the risk for delirium. But again, not to say that methadone doesn't have that additional risk, right? Because it is still an opioid itself.
Thank you.
So could you
So,
please explain the methadone to another opioid conversion ratio again, please?
Oh, so if you needed to convert from methadone to another opioid, then the ratio would be, I believe, 4.7 to 1. But I'll include that on the slides that we'll send out.
Sir,
Thank you, sir.
like morphine, the methadone also predisposed to constipation, unlike fentanyl, where the side effect of constipation precedes the benefit. In an ideal situation where logistics and financial constraints are not much into it, then we convert into fentanyl patch. So methadone does also have the same morphine constipation side effect or any reduced level of such.
So I would say with methadone, constipation is still a concern with it. And you'd always want to make sure to provide adequate laxatives.
Thank you, sir.
So I would encourage all of you to use methadone. But when you use it for the first time, there will be problems. You will not be confident, and Theo has shown you a lot of medications which has interactions which can increase QT interval or it can predispose to torsade points. All this will cause us very uncomfortable to start patient on methadone. So if you need any help, please contact us. So we have now almost 5 years of experience in using methadone. So like anybody, when we started, we were very hesitant to start methadone, even though it was available with us.
Sir,
But
if,
when we, yeah.
so for example, if we started on methadone and we have checked the ECG, there is QT prolongation. Do we need to consult the cardiologist or we need to stop abruptly? Or
Now, when you start on methadone, There are many things which can actually increase the QT interval. It is not only methadone. Other medications can also increase the QT interval. Hypocalcemia, hypokalemia, hypomagnesemia, all can prolong the QT interval. So you have to see what are the factors that is leading on to the QT prolongation. So if you think, okay, this is one medication which I can stop as of now, you stop that medication or reduce the dose of medication. If there is hypokalemia, correct it. That's the way you have to think rather than stopping methadone. So what are the risk factors that you are seeing? Then try to either correct it or maybe if not really necessary, stop it.
Thank you, sir.
That case prefers to get admitted for the first dose, no? So we have to see the investigations and be prepared for the side effects.
Not really needed, but when you start it for the first time, you are giving some unknown medication to a patient. So it is for your to reduce your stress and anxiety, you can admit the patient. Actually, it is not needed.
Okay.
Yeah, most of the time from my experience, when we've initiated patients on methadone, it was all done outpatient, just providing adequate counseling. We've already had the baseline monitoring, and then we send them home to start the new dose, and then we do a follow-up.
Okay, I think we can wind up the session for today. And thank you, Theo, with your cough and respiratory infection, and even maybe early morning for you. You came and took this session for us. Thank you very much. And now I think it's the time for feedback. So can anybody start?
We would like some volunteer to speak up regarding the entire course, regarding all the sessions generally, what you felt good and what needs to be improved. That is the most important one. Yes, I can see.
Sir,
Varun.
Can
I think we are having the assignments now, sir. So we can have, if we have a time, means we can have the discussion on the assignments, or else we can have the answer descriptions. So it will be useful for.
Okay. Yeah.
Hello, Dr. Sunil and Dr. Shri Priya. I am Dr. Priya.
Yes, yes.
Yeah, so thank you very much for this session. I have attended this course before, but this time there were a lot of new things added, especially the last one in which we discussed on how to set up the whole palliative care clinic, which was very nice. This session on methadone was very, very, very useful because it's a new drug and most of us have not been using it very regularly. And also on how to procure opioids. These sessions were very, very useful. I have attended the previous sessions and they were as usual very good, but these extra sessions are definitely something very contemporary and useful. So thank you for all the sessions.
Thank you,
Dr. Priya. And just a small correction, I am not Dr. Sri Priya. I'm just a very, very normal, non-medical person.
Okay, that doesn't matter. You have been doing great work.
Thank you.
And she is now qualified to become a doctor because she has handled a lot of virtual sessions. So
Yes.
she might be knowing many things which even we don't know.
I'm expecting a certificate from you regarding the accidents. Once you provide the certificate with your seal and sign, I might enter the field.
So actually,
Parul,
the methadone we have been getting methadone, but like what you said, with some unfamiliar drug, no? So you are a little worried on how to use. So this last chart on how do you use it, that was really very helpful. Thank you so much.
Great to hear that.
Parul?
Good evening, sir. I am Dr. Radha here. I am attending for the second time, and the course is very, very useful, and it is for the future young doctors also, and every hospital should follow that. And because to start with, and Shripriya conducted very well methodically, when to send she replied for each and every one our questions, everything. Special appreciation for you, Shripriya, for the computer technology part of it. You have did a wonderful job, and we are also able to communicate. And for the classes, sir, you then and there chat wise you cleared our doubts, and excellent speakers, and their slides are very good, very impressive, and you made us to participate by the case presentation, which is also by distant relative, one of the relatives, one of the patients. So we are able to participate through assignment. That is also very nice. And as Priya told, methadone and setting up the clinic and opioid availability, and especially SARS, Rajgopal SARS experience talk is very valuable for, and we are very fortunate to get information from Padma Shri Dr. Emma Rajagopal SARS, and your experience, comments, and tips for the future palliative care setups and clinics in India throughout. We wish for all the patients should have a peaceful end of life. Everyone should have a peaceful end of life. Through this course, we can spread the message. Thanks a lot.
Thank you, Dr. Radha. Dr. Parul?
Good evening, everyone. I think this is within the span of 4 months, this was my second foundation class. And I believe that I didn't feel that something was repeating. I think I learned something new in each and every class. It is not only about the faculties, even the candidates, the participants who were there with us. I think we learned a lot from them as well. So I'm really thankful to each and everyone. And Shri Priya ma'am, your smile and your genuine smile always brings lots of warmth in the class. Thank you so much. Sir, just one suggestion I felt, even the class, everything was very nice, sir. The study material which we got, the studies which were provided to us, they were very nice. But what I found was the year up till which it was updated, it was till 2019, sir. I think in the last 2-3 years, I didn't find a new article which was there in the study material. If possible, if you can update the study material with the recent articles, it will be, I think, more helpful for us. Otherwise, the study materials have been very useful. Thank you so much.
Okay, Shripriya, please note that. Thank you, Dr. Parul. Dr. Biju?
Good evening, sir. Good evening, Shripriya. Good evening, the whole Pallium team. Thank you so much for this wonderful session, for hosting it on cue, on time, with fantastic sessions and interactions. Thank you so much for that. Great effort has been put into it, and it has been put to good use. As all the previous speakers were saying, it was just exemplary. Thank you so much. Just a couple of suggestions. One is, again, at the timing, if you can start at 7 o'clock, it's a humble request. People like us who are working would like to come back home and see the sit with the session, because otherwise we might be driving or we might be on the way. It'll be a little inconvenient for us. That is one thing. And second, of course, what I found was, I don't know whether it is applicable to the other doctors. I could not get the session rolling on my computer. I had to watch it all on the small screen of my phone, so it was a little difficult to read the small script on the screen. So if we can have a particular link for the computer, it will be a great help. This is just a suggestion which I have gone through, the difficulty I've gone through. Otherwise, it has been fantastic. Thank you so much, Dr. Sunil, for all your guidance and all your comments. It has been great. And of course, nothing to speak of Dr. Rajgopal sir, always a guiding light, always a beautiful smile, always willing to part with beautiful stories for us, which are motivations to all the students all the time. Thank you so much, Pallium team. Thank you.
Thank you, Dr. Biju. I don't know why you are unable to open the videos in your laptop.
Yes, I don't know whether I have got an outdated software, whether that is a reason.
Maybe that happens because of some security settings in your device.
Yes,
most probably when if antivirus is installed, which prohibits
Oh yes, maybe that is the reason. Yes, I did have an antivirus. Oh, maybe that is the one it's filtering out. Oh, thank you so much for that. Because on the phone it was very easy to connect, but on the laptop it was very difficult. Thank you so much for such.
Dr. Nigel.
Good evening, everyone. So today I'm in a cab, so my video is not clear. But yeah, the sessions were excellent. And before joining, I didn't know if I would have developed that much interest in the palliative medicine. But as long as the sessions kept going, my interest kept growing. And it was very fortunate to have many sessions with Dr. Rajagopal also. Before joining the course, I inquired and I was told that it is not sure whether he will be taking the sessions or not. But when he came, and I was actually very thrilled. And yeah, I would definitely like to do hands-on training also sometimes in Cochin. I live in Delhi, so it is not very easy, but yeah, I'll definitely come there. And one feedback is definitely the assignment we have got. If we can have a discussion or at least answers for them, then it will be more helpful. Thank you, sir. Thank you, everyone.
Thank you, Dr. Nigel. And Dr. Kamal Chikli.
So good evening, everyone. And I just like to state that as a dentist, I especially found the pharmacological part very tough. For each of the assignments, I had to bother my brother, who is a pulmonologist, and I was happy when even his answers were wrong. So, so I just thought that maybe, I don't know, for dentists, like, because as what I understand is my part will always be a referral. I'm never going to prescribe the drugs. So that is what, but definitely when we see maxillofacial patients, I thought that I as professor and head, if I'm not enlightened, how do I enlighten the other part? So maybe you will need to look into many other dentists, like how do they feel the course about to be? And maybe that alteration can be done, sir, especially the case questions, sir. So thank you so much, but I'm very, like, I was very touched by the passion, the dedication, especially the talks on communication. I could just see that there was so much of depth and so much of involvement of the teachers themselves. So I think Pallium India is doing a great job, and with so much of dedicated faculty, hats off to the team. Thank you so much, sir.
Dr. Leanda.
Yes, good evening, everyone. I'm Leanda from Indonesia. I really enjoy every learning session, and for the materialization, case presentation, and also the Q&A, also very practical for daily practice. My suggestion is maybe there will be a session to discuss assignment, because by doing assignment makes me understand the material better. I'm very happy to be acquainted with the colleagues from various countries, especially India. It's great to learn together with all you doctors, and thank you very much for every faculty members, to Dr. Sanil and Ma'am Sri Priya, who have facilitated this event. Thank you.
Thank you, Leanda. So we are spreading on to Indonesia. Now Palem India has an arm in Indonesia.
I think a very junior person also. I could see someone peeking into the camera from Dr. Leander's lab, if I was correct. Maybe the younger generation there is also getting interested. That is a very good news.
Yes, thank you.
So can I?
Yes, ma'am.
Yeah.
Great job, obviously. Great dedication, and that is reflecting in each session. So the team, the hard work that goes in, Sri Priya is always available to answer. Thank you so much for all your help. And thank you to all the teachers. Deep gratitude to right from Dr. Rajagopal to Dr. Sunil sir, to everybody who's taken the lectures. It has been an privilege to attend. I am attending for the first time, and really builds up the interest in the field. So thank you so much. Just a few suggestions is that I feel some more drugs could be included in depth, like for example, buprenorphine and tapentadol or tramadol. This ones we usually start off with also. And in the last session, Dr. Rajagopal had said how it is sent in syringes and the dose is given for just 1 day, and then there is a conversion ratio from oral to IV. So, I mean, if these conversion ratios can be explained with the help of examples like Dr. Theo sir just did, telling us how the oral methadone is to be started and what is the conversion ratio, the age group, how to calculate from the OMEs. So the same reverse ratio from another opioid to methadone, what I'm trying to say, the more practical examples are given and these conversion ratios are added along with that, then it becomes easier to understand what it means. And also the wound lecture which was taken by Sister Sheba, the video is not seen in the link provided in the faculty lecture. So the video in which it's been enacted by a male patient and his wife and a sister, so that had some very important points, like if the patient has slid down the bed, how do you don't try to pull the patient against the bed sheet, you lift the patient with the sheet. So that video is not there, and you have to just rely on your memory. So I just wanted to request if that clip can be added, because for that, these are just a few suggestions. And another very big humble request to please do your 6 weeks on-site training in Mumbai also, please. Sir, thank you so much.
Thank you. I think the video is available in NHSRC website, NHSRC YouTube. There are many videos which are uploaded regarding palliative care. So all the videos are created by us. So please visit the NHSRC YouTube. So you will get many videos, and probably that video has shown in the class also. NHSRC, National Health System Resource Center.
Okay, thanks.
Regarding that video, ma'am, actually, we pause the recording during showing videos because YouTube identifies that as a infringement of law, copyright. So that is why we are forced to stop recording during playing such videos. Of course, your point is taken into account, and I will ensure that the wound management video particularly is uploaded to the study material tomorrow itself. You can access that.
Thank you. Thank you so much.
Dr. Nadeem Kotriwala. Dr. Nadeem.
Dr. Nadeem, if you are trying to say something, you're muted.
Please unmute yourself.
Hello.
Yeah.
Hi, this is Dr. Nadeem. I'm from Trinidad. I must say that I really enjoyed all these sessions. I find the timing of these sessions was concise, but able to be very informative. It was very participatory. The question and answer segment and the discussion of the cases were very, very good. My only feedback or suggestion, as many have suggested before, would probably be to do a session where we could discuss the assignments, even if not to give the answers blatantly, but at least we could have a discussion over it, because that also helps with the learning process.
Thank you,
But
Dr. Nadeem.
Thank you very much. I really enjoyed this the course.
Thank you. Priya?
In case anyone else is not having anything more to add, I think we can officially declare that the online sessions of this particular batch has come to an end. Of course, we all will stay connected through WhatsApp and email. Please do feel free to get in touch with us whenever you are in doubt or you need support. And this one batch has particularly been very, very interactive compared to many previous batches. And that has prevented maybe Dr. Sunil and myself from dozing off after a busy day. So thank you so much for all those very interactive sessions. And we do hope that we had done our small part in imbibing the passion for palliative medicine in everyone's heart. And we do believe that wherever you are practicing, wherever your area of practice is, you will definitely carry on this pattern and make the life of people around you who are suffering in pain painless. Sunil sir, you would like to add anything?
Not really, but as somebody told, the learning is not only from the faculty, but also from the participants. All of you have richly contributed to our knowledge also. I'm sure all the other participants will agree with that. It was our privilege to have you with us for the last 2 months. And some of you are going to be with us for another session. So thank you. Thank you, everybody.
Thank you everyone for joining us during the last 20 sessions. And we do hope that you all have a bright and successful career in your places. This is Sri Priya, along with Dr. Theodore and Dr. Sunil Kumar, signing off for the last time from the Tips Eco Hub. Stay connected, stay happy, spread happiness. Take care, bye-bye.
Sri Priya, please send us the invites for any national conferences in future. This one we missed. I mean, I missed.
Sure, we will do. Sure.
Thank you.
Thank you. Bye.
Thank you.